Thank you very much. Thank you. And I really wouldn't go over too much what we talked about earlier, but except to go to this slide here and show you that at Montefiore, this is the world that we live in. So we still have a fair amount of payments for each service that we render. Then we have another model where some payers pay us for each service that we render, but also then we get enhanced payments if we meet certain targets, usually quality outcome targets. Then there's something else called bundled payments, where an entire service, let's say a knee replacement, is paid as one service from the pre-op, prior to the operation, the rehabilitation afterwards, the skilled nursing care, residential. It's one payment. Then we also have what we call shared savings, where we're paid in this model, but if we can reduce the overall spend and meet certain targets, we share with the payer in those savings. And then partial risk and full risk is where we get a global fee and we're responsible for whatever happens to the patient. It is a hybrid of theirs, and there aren't really clear lines between them. As I was saying earlier, we have patients that are in this model, 300,000, and there are people who look after them, doctors, GPs, etc., who will still pay in this way on a fee for service model, because this is what they're more comfortable with, and this is what we believe was the easiest way to get them into the new model, and then to see what the upsides are and the possibilities. We were talking earlier, we see this as a rapidly moving train. We cannot afford to not adapt and innovate at Montefiore. We will go out of existence. So we have to get on the train and not try to stand in front of it. And that's sort of where we are and where we live. But happy to take any questions, if there are any. That's great. Oh, yes, yes. Oh, that too. I know. Isn't it, weird using a microphone where you don't actually hear?
Philip, this really relates to what you said in the plenary session rather than what you just said now, although it does touch upon it. So there's two things that struck me in the plenary session. You talked about how Montefiore changed your model of delivery in about 1994. That was the sort of transition point, and this is the journey you're on in that transition. And then secondly, you demonstrated some very impressive sort of quality and safety metrics. And I'm interested to know, are those two things related and connected, or are they independent initiatives that you were pursuing as a group?
Thank you. No, those are one initiative. We knew that if we decided to take the risk for 100,000 patients, for all of their care, and the only way we could actually do well in doing that is if the patients did well. If the patients don't do well, we're going to end up spending more money looking after them, or we're going to have to do something that was unethical, deny them care, etc. So it's really one vision. You cannot have capitated payments, in our view, without a relentless focus on quality and outcome. It's the ethical way to drive down the cost to actually keep people well. By the way, there's a focus on access. There's a focus. We don't get paid at the full rate if the payers, every year the payers survey the patients that we look after. They ask them about their satisfaction with access to care, appointments, attention from the doctors, from the hospital, services, etc. If the patients are unhappy, the model doesn't work either. I think perhaps as opposed to here, the patients can actually move. They can leave a payer and go elsewhere, or push their employer to switch plans. So we have to keep the patients happy, drive up, the quality, and drive down the cost at the same time. Yes. Oh, that's right. Of course.
Thank you. Can I ask a different question about the decision that Montefiore took in '94? Did you have to persuade the commissioners, the payers, the insurance side to make the changes commensurate with what you were doing from the provider side, or was the opportunity already there and it was just that Montefiore came late relative to other providers? How did that decision work on both sides?
All right, let's take that. Yeah, well, thank you. That's very important. We had to persuade the providers and the payers to do this with us. We still have to even now. And it took some time. Well, first, some said, well, we're not sure that you can do this, and they don't want to have 30,000 unhappy members. So some would say, why don't you just take the 5,000 worst cases and show us what you can do with those, or take only the primary care. We'll capitate you just for the primary care and not there. So we had to prove that we could do this and persuade people that we could. So the environment that was there before in the U.S. in the 1980s, it was called managed care. But as I was saying to the group before, it was actually managed price. It wasn't really managed care. It was about restricting utilization by putting in gatekeeping barriers. So a doctor had to make 17 phone calls to get the MRI approved. It led to very unhappy clinicians and very unhappy patients. We truly believe that we could manage the care and that the price would follow. And it was a gamble. We lost money on it the first few years, but then once we understood how to do it, it took off. Yeah. Yes. I'll give you this, of course.
Thanks. Can you track the different outcomes for those different population groups? Do you know that you get better outcomes for bundled payments, for example, compared to fee-for-service?
That's a very good question. Right now, we sort of hurt ourselves from a financial point of view because we treat every patient as if they're here. Because we can't have a system where a doctor is going through and then has to say, oh, is this patient capitated or not capitated? Yes, so we do that. The reason that it hurts us is that we're driving down costs here, but we're not sharing in those benefits. And when the patients become fully capitated, the benchmark is set at the lower expense that we already drove down. And so somebody else reaps those benefits. It's a decision that we've made, that it is the only way. We can't not have a sort of a schizophrenic system. On the inpatient service, everybody gets the same social service. We invest heavily in mental health care integrated into the primary care setting. They just, the providers do what they enjoy doing, which is looking after people without worrying about that. That's why we wish it's all here, and it's one of the reasons why we still have difficulty persuading private paying insurance companies to move from here to there, because we're helping them return better dividends they're shareholders now, and so they said, "Oh no, we're quite happy with this."
Okay. Thank you very much.
Thank you.
John.
So in essence, what I'm just going to share with you is some work that we've been doing for some time in Tower Hamlets around bringing together federated groups of primary care providers across a geographical area to deliver care. So we've got 8 networks in Tower Hamlets with a range of practices working together to deliver a range of care packages that we deliver across the system. Primarily this was predicated around trying to get practices to scale up in terms of their ambition around population health. It allowed us to think about utilising estate around workforce and to work in a much more collaborative way going forward. It's a well-established framework and is quite embedded now into the way that we work. The case for change was pretty straightforward in terms of that, so we wanted to embed principles around making sure that we had continuity of care across the system. We wanted to make sure that we optimised and used economy of scale where that was appropriate about being able to employ specialist staff. We wanted to encourage specialist clinicians to come out of acute and to support multidisciplinary working and MDTs in the community. We wanted to look at data transparency, dashboards, outcomes, and making sure that it was as patient-centred as possible. So how do we do that? What we really did is developed a range of care packages, really, which looked at reducing the variability of care. So it described the who, the what and the how in terms of how we wanted care to be delivered. What it allowed us to do is to build up a financial model that allowed us to be able to look at what we needed to pay for the care and allowed us to really have a detailed method of costing those care packages. The network principles I've highlighted, but the key change that we did around the payment mechanism is that we moved away from having a contract with individual practices to having a contract at a network level. We incentivised that payment by agreeing a proportion of the payment that went up front for the delivery of the care, but a proportion was held back based on the outcomes that were expected to be delivered. So we started off with the principle of it being a 70-30% split, and we subsequently this year have renegotiated that. So for the services we deliver on the behalf of the local authority, we've got a 60-40% split, and for the ones commissioned through the CCGs, it's a 65-35 split. And what that really means in real terms is that if you're belonging to a network, but you as 2 practices say deliver your outcomes, but 2 of your peers in your network fail to deliver the required thresholds, then none of you get paid any of that performance. So what it's really done is driven up the outcomes that we've seen across a whole range of indicators. So these just give you an indication of the things we've been doing around diabetes, but I could provide you with a set of slides across the whole range of care packages going forward. Some quite impressive improvements around childhood immunisations, which historically had been a huge challenge for us in the borough. We've managed to maintain herd immunity across a whole range of immunisations, and that has maintained throughout the timeline since we've set up the care packages. So we now collaboratively commission with our partners in the local authority against a whole range of primary prevention, network incentive schemes, as well as some of the sort of disease-specific ones facilitated through the CCG. Critical success factors, I think you'll be all relatively familiar with. So it's really around leadership. It's around making sure that we're really clear about what the outcomes are. Data transparency, dashboards has been absolutely critical, as well as sort of organisational development and facilitating this way of working. So really, in essence, what it really begins to say is that in order for this to be successful, we need to get all our ducks in a row in terms of making sure that we have the right guidance and the right education, we've got the right sort of incentives around trying to facilitate a change in practice, and we've got, in essence, the IT platform to support this, because I would say that the majority of this transformational change is being about looking at reliable, accurate data and knowing how your performance is being compared to your practice down the road. I'm going to very quickly talk about where we think the next steps are. So we've done quite a lot of work at setting up those 8 networks. We thought the sort of game was over, but in terms of going forward now, in terms of delivering integrated care, we've now got an aspiration on how we can bring those 8 networks together as one. We want primary care to come as one combined organisational form, and what we want to do is replicate the model I've described in primary care, but at a system level. So we want to see if we can set up a group of collaborative providers to work in an integrated way, which would be acute, mental health, local authority, with primary care and community health services. We've got an aspiration this year to move towards hearts and minds around designing joint KPIs and dashboards, getting them to meet on a regular basis, peer review each other around performance. Next year we've signalled that we want to move towards a more performance-related pay element around community health service and mental health, and we'd like to model or move towards a capitated model across the whole health and social care system by year 3 or at the latest by year 4. Whole range of interventions that we're delivering across the system. We've agreed that these 9 interventions down this side are going to be delivered across both Tower Hamlets footprint, Newham and Waltham Forest at scale, involving both the Acute Mental Health Local Authority and CCG partners. And then we're trying to make sure that we keep it simple in terms of the contracting vehicle. So at the moment, we're looking at using the existing contractual vehicles we've got available to us. So we're looking at using the NHS standard contract, and we're looking at make sure that we've got an integrator specification and we've got an integrator schedule that runs through all of the provider contracts to describe the new way that we think we want them to work. We're going through a non-competitive procurement process as part of the pilot process. We might move towards a more competitive process going forward, but initially this is a very busy slide and it hasn't come out well in the transferring of that. But in essence, it falls into 2 parts. The first stage is to go back to the individual providers to get them to respond on how they're going to deliver their element of the integrated care element of it. So that will go to community health service, it'll go to Barts Health, Acute, it'll go to the mental health of the local authority. And we're looking for 1 return from each of those providers. And then we're asking them to respond to an integrator specification, of which we're looking for 1 return combined by all of those providers together. That process is now on the way. The timelines have slightly slipped, but the first phase is now being completed. We've now got 3 weeks for the return of the final integrator spec in terms of how these providers are going to work in a much more integrated, joined-up way to deliver integrated care across that footprint. We're piloting it in Tower Hamlets, but the view is to roll this out across Waltham Forest and Newham, and ideally by the time we get to the sort of capitated element of it, we would want to be able to have done this across the whole of Barts Health footprint. So, not much.
Question.
How have you how are you planning to segment your population?
Okay, let's get it back now. So it's not a dissimilar process to the slides that North West London put up earlier in the presentation. So we've chosen risk of admission as being the criteria that we're going to do it. So we have equally being able to segment all our patients now across the whole of the health system. And we've done that across Welk initially, and then we've now got much more detailed analysis for Tower Hamlets, for Newham and for Waltham Forest. So I can now tell you that in Tower Hamlets we've got 1,600 patients that come in the very top end of that, around about 18,000 patients that fall in the second bucket, and around about sort of 25,000 in the third bit, and Newham and Waltham Forest could equally do the same. So our interventions are focusing at the top end of the pyramid to start with, but with a view of moving down that 20% over the next 1 to 2 years.
Divided by cost.
So it was divided by, it's cost and activity. So it was mainly looking at the risk of admission, and therefore our model and the financial analysis is predicated on reducing those unnecessary admissions by putting in the alternative services in primary care.
Other questions for
John, as I understood it, the provider integration, if I can call it that, is cross health and social care, and is being facilitated by collaboration. Is there any pressure from any quarters in any way for that to become more structural in terms of change?
Yep. So at the moment, we have agreed with our partners in the local authority that they don't, at the moment, they're not putting anything into the collective pot as a provider, but they want to join us as part of delivering the integrated function. This year, we're looking at triangulating the joint KPIs across the system. So we're attempting to try to make sure that we've got a shared set of KPIs appropriate across each of the providers. And we're looking at triangulating, particularly the response for the acute provider around sequin in relation to the things that we want them to deliver in, and then the plan going forward is for us to so rather than come to some sort of new entity, which is what we're proving to be very challenging, particularly with some of our FTs, what we're really keen to do is to make sure that we are very clear about that sort of joint schedule of how we expect them to work, and it may be that basically what we end up having to do is to go out more formally to procure to do that if we needed to do that. But at the moment we're working on collaboration and cooperation to test the model.
Is the sort of the institutional framework that you got in terms of contracts, is it robust enough to have private sector partners on the provider side, or is it just sort of something that almost works because it's within the family of NHS institutions and subject to soft negotiation?
So again, I'll take it back now. I think it's an area that I think we're mindful of, and again, I think on the journey that we want to go down is I think we want to explore then what are the contractual opportunities that I think we need to look at. But I think our aspiration is that we would certainly, so in terms of the interventions that we're looking at putting in year 2, quite a large proportion of those interventions will be targeted towards third and voluntary sector as we move down that risk stratification group in relation to that process. Another big area for us would be last years of life, so linking in with hospice care would be another big area for us to consider. So within the framework as we've written it at the moment, we have a degree of flexibility that allows us as commissioners to consider whether we think new providers need to be brought to the table in relation to that, and then equally as providers. And I think what we're going to have to try to do over this timeline is test out then whether we can use the existing contracts that we've currently got, or whether we need another type of sort of contractual vehicle, a sort of, you know, a prime vendor type contract or something different. At this moment in time, we're looking to utilise what we've got available.
So on your model, I think you were describing payments to the federations of practices. So how does that link in with the fact that, of course, NHS England are commissioning primary care? So what discussions are you having, and particularly around how that budget then gets integrated?
So the way they've set up this originally is that we're looking at incentivising primary care to deliver services over and above their core contract. So this sits above the core contract. So so we have no exception reporting in any of the delivery of any of the care packages, and it's over and above QOF and primary care services, and the outcomes that we specify are there. So initially we contracted through an APMS contract, and then through the transition we've migrated onto a standard NHS contract, and then equally at the same time we did a due diligence process around the appropriateness of being able to continue to commission these services with primary care. Some of those fell to the wayside, and we've had to go out to any qualified provider to be able to meet that due diligence element of it. But in essence, it sits across. I think going forward, we'd like to engage in some of the conversations around how do we bring core primary care into this model. I know North West London have got some aspirations, we would as well. And again, some of the work would need to do with our partners in Waltham Forest and in Newham would mean that we probably would need to be looking at that earlier rather than later with them, as that the level of investment that we had available in Tower Hamlets I think will be slightly different to the new investment that we've got in the other 2 boroughs.
So in terms of where you're at the moment, there isn't a sense that you then need to recycle some of the GMS, PMS money into this as well, or are you just keeping that out of it?
Not at the moment.
Okay, right.
Okay, so what I want to quickly brush over with you is just to look at what the structure is for the payment system and how it's been laid down by the new legislation of the Health and Social Care Act, which actually cuts in on the 1st of April 2014 in terms of the first of what's called the national tariff. And we've heard these great case studies from Philip and John about the hybrid approach to paying for health care, and the innovative commissioning approach across the whole economy of providers in a particular area. And so I'd just like to brush over the approach that NHS England and Monitor are adopting for that, and quickly talk about what is likely to be seen in 2014. a structure of how the so-called national tariff is produced is this partnership between NHS England and Monitor, and a division of responsibilities in terms of NHS leading on the scope and design of the currencies, the units within which the payments, the standard payments, are designed. And then a working agreement, and then Monitor leading on measuring in terms of standard costing of delivering services of particular types, and how that translates into a standard tariff. And I keep saying standard because the key to a successful innovation and delivery of services that best meet patients' needs and give a most efficient and effective way of delivering services is about innovation around those tariffs, while continuing to refer to these standards as the point of measurement of performance and assuring value for money. So what's next for 2014? You see, I do move quite quickly. This is this is what the process looks like, and it's basically a consultation process and issuing progressive outputs that are used for the system to engage and comment on and understand what the tariff looks like. A quick underlining of the fact that the tariff is not just a list of prices for HRGs. It's a mechanism by which prices can be set, and a mechanism for varying prices and engaging in innovative behaviour. And if you want to read more about what the general intentions are and directions of travel, we've put this reference document out. But in looking at what we've heard from Philip and John, I'd just like to refer to some of the main points in this document, this way forward document, and what the highlights and important emphases are is extended and scaled up primary care. Particularly for people with moderate mental health and physical long-term conditions, integrated care for people with chronic conditions, where a senior clinician and needing specialised care of particular types, where a senior clinician takes responsibility through a personal relationship with each patient. And thirdly, a system of urgent and emergency care, because sometimes planned care doesn't work and patients do need urgent and emergency care, and there needs to be good rules and standards around the delivery of that. And then for people who need elective care on an episode basis, something that's well known, like a hip replacement, a knee replacement, and it can be done well if it's designed well, the processes are organised well, and so on. And in many ways, the best way to purchase that within a package of care is on an episodic basis. And then there is the method of delivering specialised services. How can the payment system facilitate delivering specialised services in the best way, where a national network, or perhaps, or even or specialist networks of excellence within specialty care can be delivered. And finally, there's this idea of a collaboration with the patient taking responsibility for their health in a practical way. So the partnership with patients and giving patients a choice and a role in their health care. So they are the main headings that you'll find in this document, and it also starts to talk about how they will be developed in setting the national tariff. So I think that's all I need to say, and see if there's any questions that anyone would like to follow up on.
Questions for Rick? I think we've got time for a couple, judging by the hand signals from behind the door.
Yes. Good.
I'm afraid I haven't read your document, but if I were to read it, would it give me any hope that we could move away from a single method of payment, so payment by results, basically? Would it give me hope that we can pay over periods of time, look at those integrated models that Philip talked about, where we have different methods all working alongside each other to try and offset some of the perverse incentives for admitting to hospital?
It certainly should, and I guess it depends in terms of the culture that we see around us in the NHS, the degree to which we can think in terms of getting the best of the mechanisms that are available. And as I said right at the beginning, the important thing to note about this thing called the National Tariff document is that one of its components is a list of prices that go with HRGs. And the other is rules, guidelines and so on around setting prices via a mechanism that's called local variations. And these variations at the local level can be set ahead of the year and actually published in the National Tariff document, where a particular mechanism for providing care is decided and agreed at the beginning of the year. And so this can actually be included in the National Tariff as a guideline for doing it that way. Then there is local variations which are available for commissioners and providers who wish to bundle services in particular ways. There's also a mechanism for where the provider and the commissioner can't agree. There is a mechanism for monitor to actually make a determination that it should be done in a particular way, and this is a new innovation. So, and this would come into potentially, the scenario could be where a particular better way of delivering services is identified and practiced and put in place, and some provider commissioner relationships don't see the need for it, and so there could be a leaning on them to say, why aren't you doing it that way? So there is for my sins, I've inherited this thing called the pricing enforcement unit. But my guess is that it'll be more engaged in finding out why particular points of the system are not doing it in the best way. And I actually very much like, I hope I can borrow your initial slide, the oval one, with that hybrid mixture of different ways of paying. And so, yeah, please keep your hope and please do it.
Could I just, towards the end, do sort of one plea? Because obviously there is some encouraging words around let a few more flowers bloom and experiment. But we haven't got a particular strong tradition to really evaluate the stuff. And I was just wondering, where are our sort of collaborations with our academics so that we have some underpinning learning? Because it is really tricky when you do your innovation, also have some robust evaluation at the same time. I mean, I don't know, John, what you're doing, but you've got Bart's Health, for example, would be possible to engage them. But that's a plea so that we've got the experiments almost naturally happening now. Let's study them.
Thank you for that. And another part of the mechanism is the requirement to publish and to actually record in a way that's accessible for study. And so thank you for that, making that point. Yeah.
Okay, thank you very much.